When you bring a retired nurse back, again, it's meeting them where they are. They still want to share that knowledge that they have.
That's ACCC President Dr. Una Hopkins. You'll hear more from her up next. Welcome back to Cancer Buzz. I'm your host, Summer Johnson. With patient and survivor populations forecasted to grow in coming years, cancer programs are preparing their teams to meet the needs of those patients, and peer-to-peer mentorship is a key part of that work. Today, we're talking about cancer programs that connect early career oncology nurses with retired nurse mentors. We sat down with ACCC President Dr. Una Hopkins, Director of Nursing Practice, and the Director of Research and Evidence-Based Practice at Montefiore Medical Center in New York, to discuss the value of workforce development and empowerment.
So oncology, the landscape of oncology is changing. A lot of change happened after COVID and during COVID. And we found different ways to facilitate caring for the patient. Some of them were very, very good, and others of them have left us with a gap between the provider and the patient. But I think if we start to use the technology that we have now and the ability to get to patients where they are from that standpoint, meeting them, and I don't always mean geographically like that, but meeting them where they are in their care steps, care journeys, I think we're going to really change what oncology looks like.
Dr. Hopkins, how can creative staffing models, like the case study, be scaled for cancer programs to address those shortages and burnout?
Oh, burnout, the lovely word burnout. And I think it's just that we have to create spaces that are more psychologically safe for both our patients and our providers. And I think that once we do that, we will see burnout change, or at least the direction of burnout change. But also creating innovative staffing models is really important because there are fewer and fewer of us. Even from a nursing standpoint, if you look at Peter Burhouse's work, he says by the year 2030, we will have lost millions of years of experienced nurses. And when I say millions of years, it's calculated in the sense that if I'm a nurse 40 years and then I go to retire, that's all taking all of my wisdom, all of my knowledge, and it's putting it in the back seat of the car in a sense. But if we find a way for people like me who don't want to do a 12-hour shift 3 days a week to be able to find an opportunity to use my skills, use my knowledge, use my creativity, and facilitate growth of the new to practice nurse. I don't like to call them novice nurses anymore. They're new to practice.
Have you seen having a relationship intergenerationally provide better satisfaction on the job?
It does, actually. And I have to tell you, Summer, we're working on a project now here at Montefiore. It's going to be scalable. We started as a pilot, and it is intergenerational. The only thing that we kept the same was the nurses that were on the same shifts, right? So a night nurse, new to practice, and a wisdom worker or someone with better than 20 years practice. We put them together and we provided an exercise. And this is being done as a doctoral program project, and hopefully will be very scalable. But there is the use of intent to leave surveys for the new to practice nurses. And then there is, evaluation surveys just basically for the mentor and the mentee. Now, mentorship is very different from preceptorship. Mentorship is more to guide your career, help you with career goals, aspirations, those kinds of things. Whereas a preceptorship is really helping that new to practice nurse put in an IV, put in a Foley catheter, clean a trach, understand turning and positioning, understanding skin integrity, understanding assessments, understanding communication, discharge teaching, those kinds of things. All the preceptor helps the new to practice nurse navigate. Whereas mentorship is more along the lines of career development and understanding what one's aspirations are. So if And traditionally, we used to start nurses in med-surg just because that touched everybody. But now, nurses come out of school and they want to go into a specialty area. And so they need even more mentorship in that. So if you start out in pediatrics and you really want to go to geriatrics, okay, that's really important, right? And so it's not a matter of where the workforce is or where the workforce deficits are. It's where the nurse or the provider want to work. And how do we help them get there and shape their career?
You know, a lot of times when we're talking about workforce support and retention, we're focusing a lot on the culture of an organization, right? And sometimes I think that's interpreted in there's more free donuts in the break room or what have you. And what you're saying here, if I'm correct, is that when you're supporting someone in their career that they want to grow in, then they're automatically going to want to stick around.
Correct. And we want our new to practice nurses to stay in practice, but practice the type of nursing they want to do, right? Some of patients, and I learned this during COVID. I was part of the deployment team, and we went on a unassuming premise that if you had an RN license, you could pretty much go anywhere and work anywhere. And that was not, in fact, true. Some of these nurses had chosen to be in the ambulatory setting. Some of the nurses had chosen to be in various different other settings. You can't put a surgical nurse in an ICU because they have a different skill set. So I think when we learned that, I learned more about mentorship because of what each individual wanted to do with their career, right? So it didn't always work when we took an ambulatory nurse and put them in a med-surg unit, took the med-surg nurse and put them in an ICU, and take the ICU nurse and put them in the surgical suite. And none of that really worked well. And I think that had a lot to do with our nursing crisis after COVID.
I'd like to talk about your president's theme and how it fits into this conversation we're having. What do you hope to accomplish over your year leading ACCC?
Well, I think we've already started talking about that and looking at innovative ways to staff your cancer centers, utilizing technology the way we can use technology, finding what worked during COVID when we had these virtual visits and we were able to manage and monitor our patients differently and work with their family members differently. And I think meeting the patient where they are is really important for us to understand that. There were so many visits I did virtually that I really saw what was happening in the patient's home, and it gave me more insight into how to care for them better or how to provide discharge teaching better or how to keep them out of the hospital better because I was in their homes, right? And when you enter somebody's home, you do that willingly and they are allowing you in. So you're on their territory. So I think a lot, if we continue to use televisits and telemedicine, we will do really well with our patient population. We also keep them safer. If they're in their home environment, they're not coming into a hospital for a blood draw, or they're not coming into the hospital just for a visit or meeting with other patients and things like that. So the immunocompromised patient did really well through those kinds of visits. But also harnessing AI and seeing where we can go with AI, because it used to be a patient would come in with a pile of papers saying that they found this on the internet. And I used to tell them, put Dr. Google in the garbage can right now, because Dr. Google didn't always come up with the right answers. And the professionals needed to guide that patient through whatever it was that they needed for their cancer. So I think by using AI tools now better and helping the patient understand with confidence that they are experiencing what they're experiencing with confidence, really. I mean, I think that's part of giving us the right things. If we establish confidence in a patient on their treatment regimens, etc., I think we might even see them doing better, right? Because sometimes, if I sell you a chocolate cake, you know what you're getting. If I sell you the ingredients to the chocolate cake, you have to be part of that.
We were talking about fostering a culture that embraces non-traditional roles, where we bring nurse mentors back into the fold. What kind of role should leadership play at that, fostering that culture and leading the charge to harness that wisdom that we have in the longer-serving nurses?
I know the perfect way to answer that in the sense that I've recently been the recipient of a very large grant from Mother Cabrini, whose, mission and vision, values all are about facilitating healthcare for patients that need it. So it's all of healthcare. But in our conversations prior to the grant coming on board, the discussion around enculturation of a healthy workforce environment, the need for people to just enjoy what they're doing and have a safe place in order to do that was really important to them. And so they created this grant process to help care facilities get through the magnet journey or the pathway to excellence journey. So in those two journeys, pathway to excellence is not just about nursing. I mean, it is the highest, one of the highest awards nurses can get for their hospitals, but it has an enculturation of everyone. So it's the person who's sweeping the floors, it's the person who's changing the beds, it's the transporter, it's the physical therapist, it's the occupational therapist, it's the physician, it's the nurse. It is everybody working together with one common goal, and that is to help that patient along their journey of health. And so I thought this grant was brilliant, and I thought the reasons for it were brilliant because it did change part of the culture. I was just on an interview yesterday, not for myself, but interviewing a nurse leader to lead us down this pathway journey. And she said something that was just so wonderful in this interview. She said, you can't just come in, set the expectations, and walk away. You have to be part of those expectations. You have to really enculturate yourself. You have to get to know who are your players and how do you help them get to where they need to go. Again, all falls back to that mentoring. And when you create a culture like that, you have success written.
You said something to me the last time you were on this program that the data is there. Most of us are probably going to receive a diagnosis someday. So that's why we work so hard for our patients and training those around us.
Yeah, I mean, and screening is so important. So even, if a wisdom worker or someone who is in the retired end of their world wants to facilitate that, I mean, they can do health fairs. They can volunteer in different ways. We can utilize their skill and their knowledge set, and in so many different ways if we just think not outside of the box, but without a box.
What do you want us to remember when we're thinking about this model for our own centers?
Right. Well, I think what White Plains is doing is bringing retired nurses back, and that's a work model that's different. When you bring a retired nurse back, again, it's meeting them where they are. They still want to share that knowledge that they have. Um, they can still be teaching patients. We can still have them and utilize them remotely if we have to. The whole idea of having a virtual sitter is a big thing right now. There's virtual reality components of teaching our new to practice nurses. It's it's utilizing skills and years of experience to facilitate the growth of our new professionals. And let's face it, even if we're headed towards retirement, we are going to need health professionals to help us, right? Because we're eventually going to be there.
Next, we're talking with Josephine Lisowski, an oncology certified registered nurse at Advocate Health. She came out of retirement to help reduce burnout and increase retention of oncology nurses. As a retired nurse mentor, she shares firsthand experience about the value of this mentorship program.
I think it's very important for, I don't want to say older, but more experienced nurses to stay on to help the younger people or the less experienced people. But they bring a lot to the table also. I have to say, they bring a lot of new knowledge, a lot of computer savvy, and sometimes they can just pick up on cues from you, like how to talk to the patient or just listen. Just sit there and listen. Don't say a word. Um, so I like that intergenerational. I think the experience plus the education equals good care.
What challenges did you see at your cancer program that needed to be addressed?
One was retention of nurses. Um, They were using a lot of agency nurses, of course, during COVID when everybody did. And their nurse retention has been very high. And having people that they could call on last minute, uh, that increased their retention. So I do have statistics that they gave me that our retention has increased from years before.
What's been the feedback from the nurses that you've been training?
I've heard only positive feedback. Me and the other people who are also doing the same thing. We've heard only positive feedback. My dog is the only other person so excited to see me when I walk into a room. So they're always excited when we're here.
What does that look like day to day?
My one job will be to go around and start all the IVs and access all the ports. It just starts their day off a little smoother, where they feel like they're not behind the gun right away. I'm here for an extra hand to check medications, to assess patients. I often assess patients and tell them what's going on before they reach the room. I do copy at times. And that is, as you know, very time consuming and very tedious. It's hard for other nurses to be able to do that because they're always busy. I also give them a lunch break, and that is very important to them, where they can just step out for a minute. Just gives them a time to catch up on their paperwork. We have primary nursing here, which is very difficult, and it's a lot of paperwork. Phone calls, I can triage phone calls. I can go around to the patients, see what their needs are. So it's kind of do mini assessments all day.
Zooming out here, why do you think peer-to-peer mentorship is so important, particularly in oncology?
It is so important. There's so many little things that have to be addressed. There's so much new innovation coming like every day. But peer-to-peer, we can knock things between each other. We use this, I'll say, we'll use this drug before, and this is what we did for it. And they can say, well, then we can go to the pharmacy and find out, this is how we do it now. It educates me, it educates them.
Talk to your colleagues around the nation about how special this program is.
A lot of times, and this happened at a lot of facilities, people who have been here the longest make the most money. And we've seen a program where they took away, and this was in a hospital setting, so they took away, if you've been there 30 years, you still have to work nights. And that did force a lot of the older nurses out. I'm trying to encourage hospital management to keep the older nurses on at some point, and not just have a whole new crew. People with experience and oncology experience counts.
Thank you, Dr. Hopkins and Joe. Click on the links in the show notes to learn more about the mentorship program at Advocate Health and UNA's presidential theme, Designing Oncology Care to Meet the Needs of a Growing Patient Population. Also, don't forget, tap the plus sign on your podcast player to follow the show right now. It's absolutely free, and you'll be notified as soon as the next episode is released. Until then, for the Cancer Buzz team, this is Summer Johnson.